Now, I'll say again that after this evening at the front desk, they'll have a PDF and there'll be all the slides that haven't been included for the updated portions of the talks. Now, this one in particular, there are going to be a few segments of this lecture that do not have the slides in the syllabus. And that's because I've updated this so that really it's sort of other causes of hip pain besides femoroacetabular impingement, which is what we've all been stressing and looking at in the literature for a while. So specifically, we're going to go over the other causes of hip pain: gluteal tendon tears, hamstring tendon essentials, the other type of hip impingement, like we needed another one, Fosamax induced fractures, imaging around metal for dummies. And this is certainly no reference to the audience, more for me, because really trying to find ways to image around orthopedic hardware. And that's become a huge, huge issue recently because of the complications that we've seen with metal on metal total hip replacements. So having said that, let's go ahead and get started with our first topic, and that's looking at gluteal tendon attachments about the greater trochanter and pathology associated with them. So if we're talking about gluteal tendons about the greater trochanter, you might wonder why we're looking at a cartoon of the humerus. Well, we're doing that so that we can emphasize an anatomic theme. So let's take our humerus and let's elongate the humeral shaft. Let's take the lesser tuberosity and rotate it from an anterior and superior position to a posterior and inferior position. Let's take the space at the articular surface and its junction to the greater tuberosity and elongate it. And what we've created from the humerus is a femur, and we've done so in order to emphasize the anatomic theme that changes in osseous contour represent changes in soft tissue attachment sites, and that's something that occurs all over the body and something that I think has been emphasized quite heavily over the past few days. So let's look at this humerus in internal rotation. Lesser tuberosity off the image. Intertubercular sulcus shown here, greater tuberosity, pretty big structure, a lot of real estate there. As we move from anterior to posterior, we're going to see changes in contour of that greater tuberosity. Horizontal facet correlating with the supraspinatus attachment, the middle or oblique facet correlating with the supra and infraspinatus attachment sites, and the inferior or vertical facet that correlates with the attachment site of the teres minor. Well, very similarly about the greater trochanter, we're seeing changes in osseous contour. We have an anterior facet, a lateral facet, a supero-posterior or posterior-superior facet, whichever you prefer to say, and a posterior facet. And these changes, again, in osseous contour will relate to soft tissue attachment sites. As we consider the anterior facet, we will see that the gluteus minimus is the tendon that attaches there. Well, let's localize it by looking in the axial imaging plane. As we follow the anterior capsule to its most lateral site of attachment, we encounter this anterior shelf on the greater trochanter, and that is the anterior facet of the greater trochanter. Adjacent to it, we can see the tendon and muscle of the gluteus minimus. Now, as we take a coronal image through it, you can imagine that we're going to have to identify where we are in the anterior to posterior plane. Here you're seeing your minimus, and adjacent to it, your gluteus medius. As you follow that muscle and tendon down, you would be coming to the anterior facet. As we look at the specimen photograph on the left, and the MR bursogram in that specimen on the right, there are a few points to make. First, again, let's look at the localization, following the capsule to its most lateral site of attachment. Here, the soft tissues have been lifted off of the bone to emphasize their relationship to one another. You can see just adjacent to that lateral capsular insertion, we see the gluteus minimus tendon and muscle, and beneath it a potential space, and that's the subgluteus minimus bursa. In this case, we tried to inject this subgluteus minimus bursa by identifying that anterior facet, using fluoroscopic guidance and taking the needle just down to the anterior aspect of the trochanter. And as a testament to the intimate relationship between the capsule and that bursa, you see that while we were injecting the subgluteus minimus bursa, we got a bit of fluid into that lateral recess of the articulation. Here again, showing that nice tendon and muscle, that flat facet at the anterior aspect of the trochanter. This is very regular and reproducible anatomy that will help you localize pathology around the greater trochanter. Specimen photograph on the left and MR image in that specimen on the right. Here you see the greater trochanter and the excrescence that extends superiorly. This serves as the attachment site for the tendon of the gluteus medius. We can see that as well in the MR image. At the inner aspect of the greater trochanter, we see three tendons. We call them the P-I-E tendons, the piriformis, the obturator internus, and the obturator externus. If you see irregularity on plain film at the inner margin of that greater trochanter, you can be suspicious for pathology at the enthesis of one of these attachment sites. Now looking at the gluteus medius muscular component, specimen photograph on the left and MR image on the right. As you look at these images in the coronal plane, they are more posterior, obviously, than when we were localizing the gluteus minimus attachment to the anterior facet. Here we're seeing the gluteus minimus muscle, then the gluteus medius muscle coming to its attachment site at the lateral margin of that greater trochanter. In this case, we can see that there's a bit of enthesopathy or hypertrophic osseous change there, but can clearly identify the muscle coming down with a seamless transition to the periosteum or bone. When we talk about muscular attachment sites, really what we're saying about this is that there's no visually observable tendon component. So as we look by MR or even specimen photograph, it looks like the muscle is attaching directly to the periosteum. The transition of muscle to tendon to Sharpie's fibers to bone occurs, but it's histologic or microscopic in what we call muscular attachment sites. So the gluteus minimus is attaching to that anterior facet, wrapping around the trochanter. At the lateral facet, we have gluteus medius muscular attachment. Then posterior and superiorly, we have the gluteus medius tendon to that posterior superior excrescence on the greater trochanter. That posterior facet, or the posterior margin of the trochanter, is bare. There is no soft tissue attachment site in that location. The trochanteric bursa covers the posterior facet. Okay? We know the gluteus maximus, that extends down the posterior aspect of the linea aspera, so we're not looking for a soft tissue attachment site in that location. Well, the localization of this type of pathology has become important because our orthopedic surgeons have started to emphasize what has been referred to in the literature as the rotator cuff tear of the hip. These were first described in the orthopedic literature and were believed to be asymptomatic. So if they were asymptomatic, you may wonder how they came to light or to be observed. When orthopedic surgeons would perform total hip replacements on patients who had intractable pain, perhaps not so much in the way of gross degeneration, they noticed that as they dissected down to the joint, they found gluteus minimus and gluteus medius tears. The patient population that was involved was middle-aged females, 50s, early 60s, that were very active. So this is a patient population that appears to have a high incidence of these abnormalities, again, of the gluteus minimus and medius. Described in the literature were tendinosis, partial tears, as well as full thickness ruptures. So the orthopedic surgeons started to be very aggressive in the treatment of these tendon abnormalities, treating them much like rotator cuff pathology in the shoulder. As we look at this coronal image through the hip, we see that there's full thickness tearing here of the gluteus minimus and medius tendons. Chronicity is implied here by the atrophy and volume loss of both of those muscles. Okay? So you will think about reporting the tendon abnormalities the same way as you would in the rotator cuff of the shoulder. So repair probably would not be attempted in a case where the findings were chronic, and the implication is that we wouldn't get function back from a repair at the musculotendinous junction. As we look at the axial image on the left, we follow the capsule to its most lateral point of attachment. Here we identify that flat facet or surface on the anterior aspect of the trochanter. In this case, this tendon looks too big. There's some increased signal intensity within the substance as well as superficial to it, and we are seeing reactive marrow change at the enthesis, in this case demonstrating a partial tear of the gluteus minimus. In many cases, these patients are presenting with a very vague history, just hip pain. So they'll end up getting a screening hip series, which may be wide field of view, 40 centimeters, including both of the articulations. In these cases, sometimes it's really challenging to have enough resolution to really make specific diagnoses, but we can do it. As we look at this fluid-sensitive sequence through the bilateral hips, the first thing we identify, high signal intensity about the greater trochanter, gluteus minimus, gluteus medius. Let's move to the axial plane, wide field of view, fluid sensitive sequence here, following the anterior capsule to the most lateral site of attachment. And here we identify that tendon displaced or detached from the anterior facet. The contour looks slightly irregular here. So as Don made the point of many ligamentous abnormalities in the wrist, probably having a small osseous component or avulsed fragment, were you to get CT in these patients, it would not surprise me at all to see very small pieces of bone lifted off in the setting of avulsion. Okay, so something to look for both on your CT studies as well as on MR images clearly. These images taken from the literature, Christian Fearman's article talking about rotator cuff pathology of the hip. Again, we're looking at chronic disease here because we see abnormal morphology of that minimus extending to the anterior facet. We're seeing high signal intensity here, and we see volume loss in the muscle, all consistent with chronic pathology of that gluteus minimus. This is sort of a segue or a teaser, your appetizer with respect to our future discussion within the next half hour or so that will talk about imaging around metal in the hip. So you see that we can image around metal. We just have to try to tailor our standard clinical sequences in an effort to decrease artifact enough to evaluate the tissues that we need to. And it is very important in the setting of total hip replacement to be able to evaluate the rotator cuff muscles of the hip. Hip prosthetic components can be completely normal from the standpoint of their placement and their appearance on x-ray, but patients can present with chronic pain. That is what's classified as clinical failure of a total hip replacement. So they've replaced the articular surfaces. If the patient still has pain and limited function, it's going to be a failure from the clinical standpoint. The surgeons have identified that in some of these cases of clinical failure, the patients are presenting with tears of the gluteus minimus or medius. So don't be surprised if one of your total hip replacement MRI requisitions asks you to evaluate these soft tissue attachment sites. So if we can manage to decrease artifact enough to see the gluteus minimus and medius, it would be very helpful to the orthopedic surgeons. And in this case, we can certainly see that the gluteus minimus is intact here. The muscle volume looks normal, as does that of the gluteus medius. Image on the right, we're seeing a distorted attachment of the gluteus minimus, but a normal attachment of the gluteus medius coming down towards the lateral facet. In this case, as we're looking at a post-total hip replacement patient who presented with unretractable pain, here we're seeing tears of the gluteus minimus and medius as well as atrophy in both of those muscles. If we move to the axial plane, we can verify the presence of fatty infiltration and volume loss in both the gluteus minimus and to a lesser degree in the gluteus medius. Okay? So these rotator cuff tears are the hip. We've identified a few patient populations in the native hip, women in their late 50s, early 60s who are quite active, the total hip replacement patient, and of course, we have also identified another patient population, those undergoing renal transplant. And these patients can get enthesial changes anyway, because in some cases we'll see the findings of hyperparathyroidism with resorptive changes at soft tissue attachment sites. So that could be one of the reasons why we encounter these problems in patients, especially that have had renal transplant. Here taken from Demont's article showing pathology in this patient population. So in their article, 24 renal transplant patients undergoing MR for hip pain, 13 of them had gluteal tendon abnormalities. So we want to think about rotator cuff tears of the hip in active patient populations, again, that 50 to 60 range active female. In the total hip replacement patient who presents with pain, we want to think about it in patients who are predisposed to enthesial disease. So osteomalacic patients, hyperparathyroidism, and the like. So let's have a little quiz here. Let's look at this axial image, wide field of view through both hips, and we're going to focus on that right hip. Okay. So here are your choices: gluteus minimus, gluteus medius, gluteus maximus, rectus femoris. Okay. I'm writing questions for the board exam in the future. And so I've gotten good at doing these multiple choice questions, right? So there's a definite right answer. Okay, so as you look at the axial image, the chief thing that we want to do here is identify the facet, right? So we're going to follow the capsule to its lateralmost site of attachment. And remember, we're going to think about these tendons wrapping around the trochanter, okay? So here, anterior facet, gluteus minimus. Lateral facet, here we're going to have gluteus medius muscular attachment. Posterior facet is bare, right? Nothing attaching there. And that posterior superior facet is going to have the tendon of the gluteus medius. So in this case, we're dealing with the gluteus minimus attachment, tendinosis with superimposed tearing here. So look how thick it is, high signal intensity, and then we have some fluid in the subgluteus minimus bursa, which kind of surrounds the tendon and peeks out from underneath it. Okay, one more quiz question here. Coronal image. Now you have to kind of know where you are anterior to posterior, don't you? So you're starting to see that excrescence of the greater trochanter pop up. Look what's coming down here. That's the gluteus medius tendon, right? Main tendon. So if we come down, we're seeing, again, high signal intensity at the lateral facet. So this is going to be a muscular attachment gluteus medius abnormality. And you can see that these images are not particularly high resolution. They're coned down from wide field of view, 40 centimeter images of the pelvis. So you can make these specific diagnoses even on these screening studies that present with vague hip pain. Okay, so look for those areas. Everything is not trochanteric bursitis. Okay? So the take-home points here, again, you've heard this over and over again, knowing the anatomy is 75% of the battle. So let's now, again, emphasize this theme of changes in osseous contour representing changes in soft tissue attachment sites, and how our understanding of these changes in osseous contour will help us offer much more specific diagnoses with respect to localizing and characterizing pathology at the hamstring. So here we are at the ischial tuberosity. And what we've identified at the ischial tuberosity is that there is indeed a change in osseous contour here. There's a superolateral or oblique facet, and there's an infromedial or horizontal facet. At that superolateral facet, we're having the attachment site of the semimembranosus, and at the infromedial facet, we're having the attachment site of the conjoined tendon, it's called, because the semitendinosus and the biceps femoris are intimately associated with one another in those regions. To emphasize this point, we're showing you on the left a faxitron or high-density radiograph, and on the right the specimen photograph. So look how straight and sharp that margin of the ischial tuberosity is, and this is the semimembranosus. Now if we look at the next facet, again, very flat, easily to identify, and this is, again, very reproducible anatomy. So when you go home and start looking at your coronal recons of your CT and your MR imaging studies, you're really going to identify this, this anatomic detail very easily. So here we're having this infromedial facet, and we can see that conjoined tendon right there attaching to it, right? Now, interestingly, on this specimen photograph, look at this structure. And that's an important point that we're going to have to distinguish. At the infromedial facet, we are going to have intimately associated with it one of the adductor tendon attachment sites, okay? So this is going to be an important point of distinction, that we don't mistake an intact adductor for an intact conjoined tendon, all right? Just showing those two components of the conjoined tendon to the infromedial facet. So the point that we just made, we're going to emphasize in this case of our 34-year-old patient who is playing sports and heard a pop. This is really common with the hamstrings. You hear a pop, you feel a pop, right? So we're going to move from posterior to anterior on these three coronal images. Now, look how nicely we see this flat surface and another flat surface here. Superolateral facet, infromedial facet here, okay? So clearly we can see that a lot of the semimembranosus is detached from that superolateral facet. Now as you start to look at the conjoined tendon here, it doesn't look too bad, does it? Pay attention to the muscle, okay? Look at the next cut. Semimembranosus, there's your conjoined tendon, so this is your hamstring. Now, intimately associated to it, just adjacent and anterior, what do we see? So that's the adductor coming in. So you can imagine that if you weren't really careful here, you might run all the way down this surface and think, oh, I've got an intact hamstring here. That conjoined tendon looks okay. But you need to follow it down to be sure that you're really in the hamstring and you're not in the adductor, okay? So it's going to be medial just adjacent to it and slightly anterior. Okay, so follow on sequential cuts and also follow on the second plane of verification, which could be your axial imaging plane. The mechanism of injury for hamstring avulsions are forceful flexion of the hip joint with that knee in full extension. In adults, treatment that's recommended is surgical therapy in the acute setting. As you look at plain films such as this one, and I'm sure you're seeing just as much of this in your elderly population as we do, we see a lot of evidence of prior hamstring pathology in the form of hypertrophic enthesopathy. In this case, look at the anatomy. You can even identify it here on the plain film: superolateral facet, inframedial facet, all of this hypertrophic change suggesting a remote semimembranosus injury. On the opposite side, similarly, a lot of ossification adjacent to that superolateral facet. Here you're going to have your inframedial facet, right? So we can even see that change in osseous contour on the plain films. Kind of a busy slide, but the primary thing I wanted to do with this is to identify the spectrum of injury, and Minnie talked about that already. So we're just kind of switching our pathology in this case to the muscular tendinous junction, or to the tendon attachment rather, in enthesis. As we consider the role of MR, we want to confirm the injury, we want to determine the degree of retraction, and define the anatomy for a surgical repair, if that is the question that needs to be answered. One other thing about elderly patient populations is that often we'll see after a fall, there'll be a history of rule-out hip fracture, and the findings are in the hamstring, for instance, or a sacral fracture. I think especially when our older patient population encounters a fall, it's difficult for them to localize the pain to one location or another because they get muscle tears, they get injuries, so they hurt all over. So in those cases, always be careful, again, to survey and have as part of your survey analysis the hamstring. A few years ago, we looked at all the patterns of pathology at the PHAC, the proximal hamstring attachment complex. That's a term that was coined by one of our Australian research fellows a few years back. So we found that 82% of our cases demonstrated pathology in all of the tendon attachments. This is supported by the literature. Only 18% of our cases had pathology in one or two of the attachment sites. And in this case, you can see that there's really rupture of the proximal hamstring attachment complex involving both the superolateral and inframedial facet, with a couple centimeters of diastasis here on the right side. Similar findings on the left side with a bit less diastasis, but very similar patterns. We have seen some partial tears, though. In this case, seeing a partial tear of the semitendinosus localized to the lateral aspect of that inframedial facet. In each of these cases, though, look how reproducible that facet anatomy is. There's your semimembranosus attachment. There's your inframedial facet. You can follow that tendon is moving out laterally and posteriorly. And then, of course, just adjacent to it, we would see our adductor attachment. Okay? And then the second plane of verification is obviously looking in the axial plane, where you see the conjoined tendon here and the semimembranosus adjacent to it. Okay? So in this case, we're seeing a big area, almost like an extra piece of bone adjacent to a bone. And this is sort of a classic appearance at soft tissue attachment sites or enthesis all over the body when a patient has had a avulsive type injury in the skeletally immature stages. Okay, so when you get those avulsions, when you're skeletally immature, you get a lot of bone formation because of the vascularity in those areas. So this is very characteristic of a history of a pediatric avulsion. Okay. When we're looking at the skeletally immature patient, we want to see if that attachment site is displaced greater than 2 centimeters. If so, generally they'll go in and be more aggressive with the treatment rather than treating it conservatively and allowing it to scar down or develop ossification at the avulsive site, as was certainly the case in this patient. So the primary take-home point here is to be aware of the relationship of the adductor magnus to the PHAC proximal hamstring attachment complex, so that we don't mistake the presence of the adductor magnus for an intact semimembranous, or rather a conjoined tendon adjacent to it. Okay, so just be aware of that anatomy. Well, now we're going to move to a discussion of the Quadratus femoris, and this will lead to the discussion of a little tiny muscle that can cause a lot of problems and has been reported over the past couple of years in the literature. So this is the other type of impingement, or could be associated with another type of impingement. The quadratus femoris, again, is a little tiny muscle in the pelvis. The origin is at the superolateral border of that ischial tuberosity, and the insertion site is at the linea quadrata, the posterior aspect of that intertrochanteric crest. This muscle works to laterally rotate an adduct of the femur, and it's innervated by L4 through S1. It's outlined on this Netter diagram in red. As we look at these two MR images, axial fluid sensitive on top and sagittal fluid sensitive on the bottom, taken from O'Brien's article, we will localize this muscle, the quadratus femoris, by finding the ischial tuberosity and the lesser trochanter. We see that it's a little muscle that extends between these two structures. In the sagittal imaging plane, it runs just behind the lesser trochanter. In this case, the high signal intensity here suggesting a partial tear, and that was the topic of O'Brien's article. This has been perceived as a rare cause of groin or gluteal pain, though after we had this paper and cases such as this presented in conference, we seem to see 4 or 5 of them over the next few weeks, which often leads me to believe that they're more common than we think, but our attention hasn't been drawn to them. The lesions are more commonly encountered in women than men, right greater than left, and believe it or not, in young patients. They can be confused with hamstring or obturator externus injury, and that makes sense, right, because it's posterior thigh. They say that it's best visualized in the sagittal planes, this comma-shaped edema posterior to the trochanter, but I kind of like looking for it in the axial plane, because we can not only assess the muscle, whether it looks hypertrophic and edematous, but we can also assess the two adjacent structures, the ischium and the trochanter, for signs of chronic repetitive microtrauma, and we'll talk about that in just one second. Can be difficult to assess in the coronal plane, and I do agree with that. So again, after we saw these articles, we started seeing patients who were presenting with this type of pathology. Here's a 55-year-old woman who presented with hip pain, and this was after a fall. So as we looked at the axial images, wide field of view here, you're seeing high signal intensity. Where are we localizing? So we want to look for this little muscle between the ischial tuberosity and the lesser trochanter, right? High signal intensity here suggesting the presence of a partial tear. We said that we wanted comma-shaped edema or high signal intensity at the posterior aspect of the trochanter, and we're seeing that here as well. So in this case, you want to localize that muscle. That's the biggest part of it. And I know in the thigh, we're always struggling with these muscles because they interdigitate, they're moving from one group to another. But it's nice to have a few reference muscles that are easily identifiable, and this is one of them. Okay, so this quadratus femoris, you're not going to mistake for other things. Well, I said that we'll have to consider acute trauma, as in the last case, as well as chronic repetitive microtrauma. And another type, or the other type of hip impingement, has been quadratus femoris impingement, ischiofemoral impingement, described in the literature. Now, if you look at this plain film, it would make complete sense that this person may have an ischiofemoral impingement, right? We like to look at the secondary findings of impingement because that makes us really believe that things are happening. So as you would look for instance, cystic change at the lesser tuberosity in the setting of subcoracoid impingement in the shoulder, here at the ischiofemoral articulation, we want to see contact between the lesser trochanter and the ischium, narrowing of that space, and the secondary findings. So what might be the secondary findings? Sclerosis, cyst formation, hypertrophic bone formation, if we're looking on plain film. Okay, here certainly that space does seem narrow. It does seem like we're seeing sclerosis remodeling at both the lesser trochanter as well as the ischial tuberosity. And these were nicely described by Patty et al. In their series. So what they describe are chronic symptoms in patients who have a narrowing between the ischial tuberosity and the lesser trochanter, the narrowing less than 2 centimeters, they say. They say that the cases of edema are not centered at the musculotendinous junction, but usually within the muscle belly, and they also have inflammatory changes or edema in the adjacent fat. Tough to distinguish here between low-grade muscle strain and impingement-induced edema. That's why we like the secondary findings, right, to suggest that there's contact between that ischium and the lesser trochanter. And of course, as with all impingement phenomenon, they are clinical diagnoses, right? So on one hand, it takes a lot of pressure off of us as the radiologist because they are not our diagnoses to make. We support these clinical diagnoses by findings. So in this plain film, we would say that there's narrowing of the space between the ischium and the lesser trochanter. There's remodeling and sclerosis in both of these osseous structures. These findings could be seen in the clinical entity of ischiofemoral impingement or quadratus femoris impingement. Right? So it's for the clinician to make that diagnosis. I think this is a spectacular case taken from their article just because it really makes us believe that this person is an impinger. Look at the narrowed space, certainly less than 2 centimeters. Look at the hypertrophic change here of the lesser trochanter as well as at the ischial tuberosity. Cystic change here. Doesn't it look like that quadratus femoris is kind of getting squeezed or impinged upon there? And the high signal intensity here within the muscle. Now, you can imagine that it would be very difficult if they didn't have all these other findings to distinguish the presence of edema here from a partial tear. We also are going with the clinical history, a chronic repetitive microtrauma type phenomenon. Right? So in these cases, the secondary findings help you narrow your diagnosis as to the distinction of etiology. Okay? And remember, if you're thinking about impingement, again, these are clinical diagnoses. One more case here, Quadratus Femoris Partial Tear after a fall. And this was an elderly patient. This person was in their 70s. And in this case, again, look where we're seeing signal. Here more at the osseous attachment site. Not only on the left side, we do see some mild changes on the right side as well. Again, that article by Patty et al., as well as the one by O'Brien, suggesting that in the acute post-traumatic setting, usually the findings we'll see are more at the osseous attachment site, though you can see them in the mid portion of the muscle. As you survey the ischium and the lesser trochanter, it doesn't look particularly tight through here, does it? Nor do we see hypertrophic osseous change in either one of those areas or cyst formation. Okay? So the quadratus femoris can be an important cause of pelvic pain or hip pain in the acute post-traumatic setting as well as in the setting of chronic repetitive microtrauma. So the take-home points here to be aware of the other causes of hip pain and to know how to localize the quadratus femoris. Again, going back to our very first take-home point, and that really knowing the anatomy is 75% of the battle, isn't it? So I'm going to start off the discussion of our next topic with a case. This is an 84-year-old woman who presented with bilateral hip pain. Okay, so clearly she's had some postoperative change in the spine. And this gets to truly be an unknown for you because the next segment I don't think is in your syllabus with respect to the slides. So I'm really going to be testing your knowledge here, your eye, I guess, in the first place. So, if you look at things initially, especially as a musculoskeletal radiologist, and don't see something that jumps out to you. When we're first starting to read bone plane films, we have our residents and fellows follow margins of cortices, and they should be absolutely smooth. And if they're not, we have to consider why. So we follow our cortical margins around the femur, and we've got a bump here. So if we've got a bump, the first thing we ask ourselves is there a soft tissue attachment site there? Because look, looks like there's one on both sides. It's kind of bilateral and symmetric. So in this case, we don't want to be fooled by the fact that a bilateral and symmetric process may be, number one, a normal variant, or number two, a soft tissue attachment site. So there is no soft tissue attachment site in that location. And this pathology ends up being a Fosamax-induced stress fracture. So how many of you have seen these in your practices? I see a few hands. Yeah. So I'm surprised that it's so few hands. So let's go over the findings here. And as you go back to your practices and look at your hip films and your femur films, really look closely at them because this diagnosis can be a very, very tough one to make. So here we're showing you sort of a close-up view and the frontal and the frog leg lateral. The Fosamax-induced stress fractures link between prolonged bisphosphonate therapy and atypical femur fractures. So the theory here, they're not exactly sure what's happening, but they think that bisphosphonates suppress the bone turnover and result in skeletal micro-damage accumulation. So the osteoclasts are inhibited and the osteoid matrix that's laid down is abnormal. So it's not effective here when we're getting these insufficiency or stress fractures. They're called stress fractures in the literature, and I really think they probably are more likely an insufficiency fracture, right? Because this is abnormal bone that's being laid down, and that's what's failing. So I really like this article that was produced in the literature by Dr. Chan from, I think he's from NYU. Kathy Perchprava is in the audience here. I think this came from their practice at NYU. So this is a really nice article, and it summarizes a lot of the findings. So I'm going to show you the findings that they reported that are associated with these bisphosphonate-induced fractures, and I'm going to illustrate them with cases from our own fractures, and we have cases from our own institution, rather, and we've seen a lot of these. So look for them in your practices. So the fractures, here's the scary part, can be located from 0.5 millimeters below the lesser trochanter to 18 centimeters below the lesser trochanter. So look at this one. This is a case that we saw in our practice. So if the patients come in and don't have any really considerable history of trauma, and you're seeing a femur fracture, and they hadn't had previous femur films, look closely to see if you can identify anything in that fracture that might clue you into the fact that this is a bisphosphonate-induced fracture. In this case, you'll see this heaped up margin at the lateral cortex of the femur. But once you've got the pathologic fracture, it can be tough to identify those underlying findings that predisposed to it. Now, the most common age group are women aged 50 to 81 years, and these are people who have been on bisphosphonate therapy. Alendronate therapy has been reported in particular, and usually it's 4 years. So the range in this article was 4 years to 14 years. So we're talking about chronic bisphosphonate use here, okay? So not somebody that's just on them. Okay. So number one in this case, be aware that you have to look all the way down the femur. Run the femur when you're looking at your hip series. So don't just stop right at the level of the joint line when you're looking for fractures. Okay. The next thing that they described was a medial beak and varus angulation with these fractures. And it kind of makes sense because the fractures occur initially at the lateral cortical margin, right? So when you're laying down this abnormal osteoid and then you have the further insult that completes the fracture, if you're starting in the lateral cortex, the biomechanics here suggests that what's going to happen is the fracture line will propagate obliquely and proximally as you move medially. Okay, so the medial beak, they're talking about this. And again, what this pattern is helping you to do is to try to, if you get a patient who presents like this without a very severe history of trauma, you're going to think about whether or not it was a bisphosphonate-induced fracture. Because don't you think it's tough to identify the changes of remodeling on this lateral cortex? Okay, this patient did have previous films with established it. They talk about a skirt of focal buttressing at the lateral cortex. So that's this stuff. Let me show you a close-up. That's the skirt of focal buttressing at the lateral cortex. And I would suggest that the findings that we see could even occur first endosteally and then move across the cortex to involve the lateral margin. And I say that because of some MRI studies that I'm going to show you in a few minutes. Okay, so we're looking for endosteal lateral cortical changes and a skirt of focal buttressing. Very characteristic of these bisphosphonate-induced fractures. There's an increased propensity for bilateral involvement. So if you see it on one side, look for very subtle changes on the opposite side. Now, here are the MR findings that I wanted to share with you. This set of images, or this image, was given to me by another radiologist from NYU as well. So as you're looking at this fluid-sensitive sequence, look at the changes at the endosteum. We're getting reactive marrow change here, chronic process perhaps, bilateral and symmetric. We're not seeing a lot of periosteal high signal intensity. We see no linear high signal intensity extending across the cortex, do we? Okay, so endosteal change along the lateral margin of the femur. Think about, be looking for that history of bisphosphonate therapy. Get a plain film, get a CT if you have to. These patients have a high risk of going on to complete fracture. And the orthopedic surgeons now, when they see this, in many cases are prophylactically rodding these patients. Okay, so your input is really crucial in preventing a fracture. Here's another example of how subtle these things are. So here's the plain film. This was a person who was on bisphosphonate therapy chronically, had femur pain, got femur films. Okay, what do you think? Hard pressed to say a whole lot, right? But we are alerted to the fact that we're looking at the lateral cortex, and we're alerted to the fact now that we think that endosteal changes may predominate initially. So kind of subtle, but look at that. There we have our person's nuke med study, which had us move on to an MR imaging study, okay? And these are kind of scary, aren't they? Because the plain film findings are so subtle. So if you have a predisposed patient population, I would not hesitate to say in my dictation, subtle or no findings with clinical suspicion, recommend that this person has MRI. When you protocol that MRI, be sure you run that femur, because we know that these lesions can happen so far distal to the lesser trochanter. We don't want to miss it, right, and have these fractures go on to complete. So what I find really interesting about some of the MRs I've been seeing, endosteal change. Look at the high signal intensity here. Here's the region of the abnormal osteoid starting to develop on the T1. So subtle, the endosteal irregularity. And then when we look at the axial cross-section, you're seeing, again, this endosteal high signal intensity, and this is in the region of a nutrient foramen, okay? But endosteal change predominates initially, so be careful to read that closely when you're looking at the MR images. So the take-home points here are a high association of bilateral involvement with limited symptoms indicating screening of both hips. And I should really say here both hips and femurs because of that low involvement that we can encounter. A subset of fractures, again, occur well below the lesser trochanter. Be sure your entire femur is well evaluated, and the MR findings can be subtle and focused at the endosteum. So don't just blow them off, okay? Because I think sometimes it's so subtle, I'm not sure if it's real or not real. Hopefully you'll have that history of a bisphosphonate patient, and so be careful about not overlooking these subtle findings. Okay, well, in the last 15 or 20 minutes, what we're going to focus on is imaging around metal hardware, or orthopedic hardware. And again, we're going to add these images to PDF that will be emailed to all of you. So you're at an advantage, I guess, in that you get to be very interested in these topics and have to wait until you get home to look at the hard copy. So I'm going to tell you a few things initially that you all realize anyway. Metal artifacts are similar to susceptibility artifacts. We know that. They're usually represented by an area of signal void, often with an area of high signal intensity adjacent to it, and they often demonstrate areas of geometric distortion. So here we're looking at total hip replacements in the bilateral femora and acetabulum, and you can see this actually looks pretty good. You're probably impressed with those. Well, you can see that it depends on the amount, the configuration, the orientation, and the composition of the material that we're using. So if we have titanium, we're going to do pretty good just with standard clinical sequences. We're not going to have to do a whole lot to reduce the susceptibility artifact. But if we're dealing with stainless steel, and that's what we're primarily dealing with a lot of patients who had these surgeries 5, 6, 7, 8 years ago, we're going to be dealing with pretty significant artifacts. Look at the difference in these two cases with cobalt chrome on the left and zirconium on the right. So pretty significant difference. These examples taken from Raphael's article in AJR. Titanium implants are spectacular because they have so little surrounding artifact. And then this femoral resurfacing patient, you can see, we can even see that stem extending into the femur and the osseous configuration around it. So let's go over some of the MARS imaging techniques. So if you've heard people talking about MARS, metal artifact reduction sequences, things we can do with clinical sequences to reduce metallic susceptibility. So you can clearly see that this patient had a scaphoid fracture, and perhaps the surgeon wanted to assess the osseous healing here, or perhaps they want to get this study to look at other things. Maybe the scapholunate ligament, the lunotriquetral ligament, the TFC. In any case, you want to decrease the artifact here so that you can potentially affect the area or identify and diagnose pathology in the area of the prosthesis as well as the adjacent soft tissues. So if you look on this MR image on the left, a coronal T2 fast spin echo no fat suppression, you can see that we've pretty effectively minimized artifact enough that we can see that there's at least part of the scaphoid that does not have bridging callus. You can see that when we use gradient techniques, we get quite a lot of blooming artifact, which affects adjacent soft tissue. So this is a common sense thing that everybody knows. Don't use gradient echo imaging in the presence of metal. A few other basic things. Again, these word slides are a little bit busy, but when you're going back to your lectures, when you get the PDF, it's kind of helpful so you don't have to be taking frantic notes and things like that. Turbo spin echo sequences are preferred over spin echo sequences because those multiple 180s are applied within a single TR and result in a shorter effective TE. So when you shorten the TE, you're going to get a bit less susceptibility. So you want to use shorter TEs and you want to use turbo spin echo technique. Common sense again, lower the field strength. It's preferred over high field strength. So you double the field strength, you double the artifact. Simple concept, right? If you have 0.2 or 0.5 Tesla imaging, while you might not like it for a lot of your sports cases, it would be great for metal implant cases. Okay, so move them to a lower field strength magnet if you can. The other thing we can do, and these are all things that intuitively would decrease image quality in the absence of metal, right? And that makes sense again because we're decreasing signal to noise, and that's going to decrease the susceptibility artifact, okay? So things that normally would make an image bad are going to make your metal susceptibility artifacts less. That's a simple message there. So you decrease the voxel size, you increase spatial resolution, you decrease SNR. That's what we're going for, again, decreasing SNR. We can also play with the phase encoding and frequency encoding direction. So you can see in this axial image through spinal hardware that by changing phase and frequency, we change the distribution of the geometric offset. So if you have a very specific question, and if you're going to image around metal, you want to know what the question is that you're answering so you can tailor the study to be able to answer the surgeon's or the referring physician's questions. You can play with sequences like this, and you can take the extra time to do 2 sequences in the axial plane, switching phase and frequency encodes. Then you might not want to do the sagittal plane or the coronal plane because your answer, or the question would be better answered in the axial plane. Okay? That's why it's important to know what the question is that the referring physician is asking. So in cases like this one with very extensive hardware, again, it might be very useful to do an axial plane flipping phase and frequency on both sides. It's a good utilization of your time, not a bad one. Another common sense thing, we avoid chemical fat suppression. And by the way, these common sense things for you are not common sense things to your technologists. Okay? So if you say, well, do the classic things we would do for imaging around metal, that's going to be totally foreign to them unless they're used to doing it. So it's not, they'll do a gradient sequence, they'll do chemical fat suppression, they'll do everything that you don't want them to do because it's not in their mindset. Right? So as we start to image more and more around metal, it will become a part of their mindset. But until then, I think you have to be very specific with your protocols. So say, don't use gradient imaging. Don't use chemical fat suppression, right? They're not going to do things that would make an image worse to them, right? Because normally you want to do the other. So you have to be very specific with your text. Fat suppressed T2 and fat suppressed T1 weighted images here with contrast show pretty significant susceptibility around this hardware for the rotator cuff repair. When we use STIR, you see that we markedly decrease that artifact. So inversion recovery, while it has less preferred resolution, does not have as much artifact as chemical fat suppression. So ditch all your chemically fat suppressed sequences, replace with STIR. Here is one of the biggest things that can help you out. Increase the bandwidth. Max it out. This is going to decrease metal artifact and most artifacts. It's going to decrease your SNR, so it's not going to give you a nice image normally. But by doubling the bandwidth, you decrease your SNR by 40%. You decrease your susceptibility artifact by 40%, right? So you can see that nice example here in this ACL reconstruction. Short bandwidth, long bandwidth. Shown here a lot less artifact around that ACL tibial tunnel hardware. Okay, so really basic things that you're doing with your standard clinical sequences. And again, that's been referred to as MARS, Metal Artifact Reduction Sequence. And this is the summary. So you're going to increase your bandwidth 2 to 4 times, kind of maxing that out. Use turbo spin echo sequences, no spin echo sequences. Get rid of chemical fat suppression and substitute with STIR. Lower field strength imaging if you have it, certainly not on your 3 Tesla scanner. And if you have access to 0.2 or 0.5, send them there. You can flip phase and frequency to help you manipulate the artifact and see different areas of the tissue. You're going to decrease voxel size, and you can use some tailored RF pulse sequences if you have access to them. And let me show you a few.
that are being developed and that are part of some limited research packs on certain vendor platforms. So here's imaging of a total knee replacement, fast spin echo imaging on the left. And, I wouldn't complain too much about this. I've seen a lot of incredibly bad imaging around metal, and this isn't horrible. It's bad, but it's not horrible. So the Maverick sequence is something that's being developed on the GE platform. It's not yet released. The CMAX sequence is a sequence that's developed by Brian Hargraves at Stanford, and it's not associated with a platform. He's patented it. So you might see CMAC being used on all of the vendors because once it's patented, they all have access to it, and they can sort of purchase it like a product and develop it further. So the Maverick and the CMAC, those acronyms are spelled out here, use different methods to decrease susceptibility artifacts. And you can see that in these images, it's definitely an improvement over the fast spin echo sequence. I'll tell you that we're working with CMAC now. My physicist and I, we got this sequence from Brian Hargraves at Stanford. And we're playing with it an awful lot to get it to be kind of a plug and play. So it's definitely not yet ready for prime time, but when we can get it to work, we're getting some images that look like this, that markedly decrease the susceptibility artifacts. So I would be looking for sequences like this over the next year or so, okay? Another example here of a CMAC case. This is a frontal radiograph, obviously, in a patient with bilateral total hip replacements. Here's our T1 fast spin echo. As we look at the T1 and the PD-CMAC, you can see with our T1 FSE, well, it's kind of hard to assess what this guy is. Is it just, part of the posterior aspect of the bone? Are we dealing with anything abnormal there? But when we used the CMAC, we were able to identify this fluid collection posterior to that greater trochanter, okay? And if any of you have had requests or emails or watching TV where you see these advertisements from the lawyers, have you had a metal-on-metal total hip replacement? Do you have hip pain? Call us at 1-800, right? Well, you might know about the next process that we're going to discuss, the complications of metal-on-metal total hip replacements, metallosis, this process is called, and why imaging around metal and decreasing susceptibility on MR is so important to a patient population that I think we are only going to see balloon in the next year. I mean, already we're getting quite a lot of requests for MR evaluation of these patients. So here's a case study of the next thing that we're going to discuss and the final of our time together, metallosis, or the complication of the metal-on-metal total hip replacement. These patients, again, scary, present with dull, aching pain. Not too bad, maybe so slight that they may barely want to mention it to their orthopedic surgeon on follow-up. So very vague, right? In this case, let's look at our metal-on-metal, and what we're seeing here is something called edge loading. So we see this lateral migration of the femoral component in the acetabular one and a mechanical phenomenon here in the bone at the junction of the acetabulum to the acetabular component. Well, look what this patient ended up having. A huge fluid collection at the posterior aspect of the joint. In this case, look at the signal intensity of the capsule surrounding that fluid collection. Pretty dark, isn't it? Okay. And this is a phenomenon and the findings of a complication called metallosis. Now, Don said previously that he jokes with the orthopedic surgeons, and I think he said, what was it, ESPN or U.S. News and World Report was the best orthopedic journal. Well, maybe New York Times has some competition because they reported concerns over metal-on-metal hip implants, and patients started coming to our surgeons in droves because they realized that this complication was happening and that the symptoms were so very vague, right? So how many of you have seen these or heard about the complication of metallosis in metal-on-metal totals? Okay. I see quite a few hands, and again, I'm surprised there aren't even more. So let me tell you something scary about metal-on-metal total hip replacements. And I was flabbergasted when I was talking to my surgeons about this because they said to me, and we've always known that if you have an anteverted acetabular component in a metal-on-metal, you'll get increased serum metal ions in your patient. Does that not bother you? That would make me petrified if my surgeon told me that. So that means those metal ions are floating around. They're depositing in my brain, my liver, my spleen, potentially. but they were very cavalier about it. Now, that just means that we can't have them anteverted in any way. All right. Well, as a segue to that, patients have developed this problem called ALVAL, aseptic lymphocytic vasculitis associated lesions. And I think the shortened way to consider these things are metallosis. The patients present maybe with pain or squeaking, elevated serum levels of metal ions, elevated inflammatory markers. They get perivascular lymphocytic infiltrates without evidence of foreign body reaction and acellular necrotic tissue. So if you look at this case, right, here's your metal on metal total hip replacement, and you think, gosh, it looks pretty good. I don't see anything going on there. Look at the soft tissues, window up the soft tissues, and what do you see? A big fluid collection here. So don't think about this like particle disease because it's different. With particle disease, we've got polyethylene wear, and the particles are big. They're big enough that they activate the macrophage system in the synovium so that the macrophages start eating up all of these polyethylene particles, and they make a mass like synovitis. Okay, so it's synovial hypertrophy. So that burrows into the bone. It's not the case with metallosis. These little particles are too small to activate that macrophage system. So what happens here are you get these aseptic collections of fluid. The problem is these aseptic collections of fluid cause tissue necrosis. That's localized, not to mention the fact that they're in their serum as well. So let's not think about that because that's just too much of a complication to think about at this time. And what are we going to find, in 20 years when some of these patients undergo autopsy? Who knows? At any rate, there's been a grading system that has been introduced in the radiology literature, and it's not a spectacular grading system, but I think as we see more and more cases, we're going to be able to better characterize this process. So the grading system for metal on metal total hip replacement complications was proposed by Anderson et al., and that's just a recent article. So they talked about A, normal or acceptable, B, infection. So they're trying to make this sort of a global classification system to cross different types of complications. C1 they called a mild metal on metal disease. And for this, they're talking about paraprosthetic soft tissue masses with no hyperintense T2 weighted fluid signal or a fluid-filled periprosthetic cavity. So in this case, you're seeing this cavity, low signal intensity around the border, and less than 5 millimeters in the maximum diameter. Okay, there's C2, moderate metal on metal disease. They talk about paraprosthetic soft tissue mass, a fluid-filled periprosthetic cavity greater than 5 centimeters in maximum diameter, or a C1 lesion that presents with, sorry about the typo, muscle atrophy or bone marrow edema. Okay? And there's C3 lesion, fluid-filled cavity extending through the deep fascia, tendon avulsion, intermediate T1 weighted soft tissue cortical or marrow signal, or a fracture. So what this gets to is the fact that if you have a fluid collection around these metal on metals, it suggests that you may have the ions in that fluid collection. And when you get the fluid collection, it causes tissue necrosis. Okay? So the problem with these things from the surgeon's standpoint and functionally is that when you get tissue necrosis, it's pretty hard to revise the total hip. Okay, there's been a huge recall by DePuy. So what that recall has involved for all these patients who have metal on metal total hip replacements is that they are to be surveyed by MRI for 5 years. There are hundreds of thousands of total metal on metal hip replacements floating around out there, and we've just started to scrape the surface in San Diego. So our surgeons are asking for more and more and more of these every single day. So imagine all these people being surveyed every year for 5 years. Okay. If a fluid collection is identified, they're going to try to aspirate it and see if there's ions. They're following these patients' serum ion levels. This is a huge, huge deal. And I've gotten 10 or 15 emails from these medical legal standpoints looking at things like this. Here was a patient from our practice, dull aching pain status post metal on metal total hip replacement. This is a C3 complication, a huge fluid collection. They make the point in the article by Anderson et al. That the capsule looks low in signal intensity on all imaging sequences, suggesting that some of those metal ions are actually collecting in the capsule. The tendon avulsion here suggesting already the presence that you're having necrosis of adjacent soft tissues. And these people are big problems, again, for revision in the orthopedic surgeons. Taken from the orthopedic literature, this is such an interesting phenomenon. Rates of metallosis related revision 3.1% at 5 years, and in a specific subcohort, younger women, so women in their 40s and 50s, the complication rate is up to 13%. Okay, so this is really a big problem. This is another patient taken from our practice. Here you can see again that metal and metal total hip replacement. I wouldn't say much about the plain film in this case, but they had a huge fluid collection. They had tendon avulsion as well, suggesting the presence, again, of tissue necrosis and soft tissue failure. So the take-home points here about imaging around metal and about metallosis in general are to be familiar with basic means to reduce metallic susceptibility artifacts. Not that you need another mnemonic, but here's one that might help you out a little bit. So increase the bandwidth, play with phase and frequency encode, decrease voxel size, inversion recovery, no fat suppression. Be aware of the complications of orthopedic hardware. We focused on one today, which is a truly hot topic in the orthopedic and radiology literature, that of metallosis, or some refer to it as ALVAL. And in the setting of the metal unmetals, know that you're looking for fluid collections and tissue necrosis. So hopefully this last hour of sort of hot topics and other causes of hip pain have offered you some new things to take back to your practices and some things that will help you protocol your studies. Thanks so much for your attention.